In this video we're going to discuss normal pressure hydrocephalus, also abbreviated NPH. And normal pressure hydrocephalus essentially is a condition in which there is a defect in the CSF resorption. The cerebrospinal fluid is not being resorbed like it should, and as a result it builds up in the ventricles. So you get increased CSF in ventricles of the brain, and that can lead to the symptomatology. And there's three classic things. It's called a NPH triad, and those three classic things, very important to remember. And the first one is a gait disturbance. These patients can have a classic gait disturbance that almost seems like their feet are sticking to the floor, almost known as a magnetic gait. So that's the first part of this symptomatology. The second one is a urinary incontinence. And the third one is oftentimes doesn't occur until late in the disorder, and that's dementia, progressive dementia, memory loss. So remember that NPH triad. So then, if a patient does indeed come to you with these three things, or even two of the three things, because dementia is late, often late finding, how do you proceed? Well, obviously, you do a clinical exam and assess their gait, and assess their memory, and talk to them about their urinary incontinence. But the key test, of course, is the neuroimaging, either a CT or an MRI. And then another thing that's done that's actually very important is if you are pretty convinced after you do the CT and MRI that this is indeed NPH, normal pressure hydrocephalus, you do something called a diagnostic lumbar puncture. Diagnostic lumbar puncture. And this lumbar puncture can also be therapeutic, in the sense that what you do is you remove some CSF, maybe 30 to 50 mLs of CSF, and over the course of the following few hours, the patient's symptomatology can improve. And if that indeed does happen, then you've confirmed the diagnosis of NPH. Wanted to show you neuroimaging. This is either a CT or an MRI, and this is of course the normal brain, and as you can see, it's very, very obvious in NPH. The ventricles are quite dilated because of the accumulation of cerebrospinal fluid, CSF. Alright, so then how do you treat this? Well, the lumbar puncture test probably made you kind of think in terms of how this may be treated, and really what you have to do is you have to remove the CSF, and the lumbar puncture can of course remove the CSF, but unfortunately, because this is an ongoing problem, this is a problem of CSF resorption, this really is treated with something called a VP shunt, and VP stands for ventriculoperitoneal, and I'll explain what that means with the diagram. So here's a VP shunt right here, and up here are the ventricles that are enlarged because of the accumulation of the CSF, and the shunt starts right up there, and it drains the CSF into the peritoneal cavity. That's why it's called a ventriculoperitoneal shunt. And the excess fluid is actually drained into the abdomen, and this shunt helps remove the CSF and can result in a gradual and steady improvement in the symptomatology that NPH patients have. I wanted to close off with some vignettes, and here we go. Alright, first one. 70-year-old man is admitted to the hospital for delirium associated with urinary tract infection. Upon adequate treatment of the infection, patient's mental status improves significantly, though he is noted to remain partially disoriented. He also has impairment in short-term memory, difficulties in naming simple objects, and impaired concentration. His family members confirm an 8-month history of gradual progressive decline in cognitive abilities, which they attribute to old age. However, the man is no longer able to manage his finances and gotten lost while driving to the grocery store on 2 occasions. Prior to discharge from hospital, the nursing staff reports that the patient continues to have urinary incontinence, though his infection has resolved. He is also noted to have very unsteady gait, requiring assistance when walking. No other obvious signs or symptoms, which disorders most likely accounts for this patient's dementia. Well, it always helps to have talked a little bit about the condition right before the vignette, because it makes it very easy. But this is the type of vignette like you want to be comfortable with on an exam, where even though it's long, if you can kind of notice the triad, that NPH triad, in their description of the patient, it can lead very quickly to the right answer. And finally, one last one. A 72-year-old man comes to clinical attention with progressive memory loss, urinary incontinence, and gait instability. MRI of the brain shows dilation of the ventricular cavities, while the cerebral cortex appears normal. No infarcts are seen. Repeated lumbar puncture reveal occasional increases in CSF pressure. The biopsy of the frontal cortex demonstrates the absence of neurofibrillary tangles and senile plaques. Which of the following is most appropriate treatment? I wasn't able to fit in the answer choices, but I can always write in the answer choices real quick. The answer choices were A, acetylcholine esterase inhibitor, B, aspirin, C, levodopa, D, ventricular shunt, and E, vitamin B1, also known as thiamine. Well, most of these are used to treat some neurologic disorder. As you know, this is Wernicke's, this is Parkinson, this is used to decrease stroke risk, and this is used to treat Alzheimer's. But we all know that this vignette is describing NPH, and the treatment of NPH is ventriculoperitoneal shunting, also known as VP shunting. So the answer is D, VP shunting. You place a shunt that looks just like this, right here.